So of course, bone is really an organ that's comprised of many different tissues. There's the trabecular bone, which is the spiculated bone in the center of a bone, and then there's this hard outer shell of bone, the cortex. And in weight-bearing bones, there's an articular surface. And each of these compartments acts in a different way, responds to stress and hormonal stimuli in different ways, as we'll talk about. So the trabecular compartment is really made up of a honeycomb of bone. Here's the microarchitecture on a scanning EM view. And it is this interlaced interconnections that are responsible for the structural integrity of trabecular bone. And when trabecular bone becomes deficient, you see thinning of these trabecular plates, you see perforation of these trabecular plates, and eventually it loses its structural integrity. And there's a bigger surface of trabecular bone than there is to cortical bone. So many of the effects of the drugs that we use, many of the insults to the skeleton are felt first in trabecular bone. But the cortical bone, of course, is critically important as well. And in fact, is very important at preventing fractures, even in sites that we think of as classically mostly trabecular in composition, like the vertebral bodies. Although the cortex in the vertebral body is thin, it actually contributes a fair amount to the structural integrity of that bone. So bone is complex because it not only is important for our locomotion and for storing chemical constituents like calcium and phosphorus, but also houses the hematopoietic system. And the hematopoietic system interacts very intimately with the cells of your bone, and we'll touch briefly on that. So there are two very distinct processes that are involved in the development of the skeleton and then the process of renewal and repair of the skeleton. So during growth, when your bones are getting bigger and longer, the process is bone modeling. And that process occurs most simply for us to understand in bones like in the lower extremity, in your femur, where there are epiphyses where there's cartilage that allows the bone to elongate. And at the growth plate, the bone is growing because the cartilage eventually turns into bone at the more proximal end, and at the more distal end is extending upward. Similarly, at the articular cartilage, this bone is expanding. So there are growth plates that allow the bone to grow. There's also appositional growth along the side of the bone. So cartilage is being replaced by bone here at the growth plate here, and cartilage is being replaced by bone here, and a third place here as the marrow cavity expands. So the bone is getting longer, and the cartilage goes through a very complicated series of developmental steps that allow it to expand, and eventually the cells down here die and are replaced by bone cells. On the sides, there's periosteal bone formation that allows the bone to get bigger. So bone modeling occurs during growth, but there's also an element of bone modeling that occurs after epiphyseal closure, after your bone is made. I should also point out that bone modeling during growth is part of the process by which the bone is sculpted. The bones adapt the shape they do because of the mechanical and gravitational forces that are put on the bone, and that's why the bones develop the shape they do. After epiphyseal closure, one of the very important things that people are hoping to do in drug discovery is stimulate new bone formation on sites where there has not been any active resorption. So quiescent bone surfaces where we're going to form new bone. And we'll talk about how that might occur a little later on. So modeling we usually think of during bone growth, but modeling after epiphyseal closure is new bone formation on quiescent bone surfaces. In drug discovery for osteoporosis, this is the holy grail. That is, bone lining cells that are normally present on quiescent bone surfaces turning into bone-forming cells. So the way that bone remodeling occurs, that's the typical process by which we repair bone if you get a microcrack. It's the process by which we call upon bone if we need to defend our serum calcium. It's the process by which we call upon bone if we need to buffer a systemic acidosis. That process, and for our purposes in particular in repairing bone, is the process of bone remodeling. And that is a highly orchestrated series of events that occurs in what's called the basic multicellular unit. It involves several sets of cells that include osteoclasts, so-called transition cells, and then bone-forming cells. And this occurs in a highly orchestrated fashion that begins with bone resorption, that digs out an old or damaged piece of bone. Then there's a reversal phase during which these reversal cells are present, followed by a period in which there's bone formation to repair the deficit that was developed by the osteoclast. And this is a pretty long process. The resorption phase is fairly quick, over about 50 days, but the entire remodeling cycle occurs over about 200 days. In young individuals in their 20s, you actually turn over your entire skeleton. You get a whole new skeleton in the course of a year or two. But in old folks like me, this process is very much slowed. But this process is fundamental to understanding many of the drug therapies that we use. And the cells that are involved are shown in this actual photomicrograph of bone from a patient with hyperparathyroidism. Here are the osteoblasts, here are the osteoclasts. They're multinucleated cells. They've resorbed bone. The scallop resorption pits have been made by these osteoclasts. Then there's a period where there's no bone cellular activity, followed by these osteoblasts forming new bone. And they do so in a two-step process. They lay down this proteinaceous scaffolding called osteoid that is mostly made of collagen, which is then subsequently mineralized through a process that's initiated by the osteoblast. Controlling this cycle of bone breakdown followed by bone formation are cells buried in bone called osteocytes. And these cells turn out to be the maestros, the conductors of the orchestra. They control the pace and the recruitment of these cells to the bone remodeling cycle, and have now become a very major focus of our understanding of bone biology, as well as our therapies, as I'll come to. So there are some refinements of that basic bone remodeling element, that multicellular unit, that have become clarified recently. One of them is that in trabecular bone in particular, that is that spiculated bone that sort of looks like a honeycomb where there's a large surface exposed to the marrow environment, it looks like it's actually occurring in a confined space under a canopy of bone lining cells, shown here. So the whole process of resorption, reversal, and bone formation seems to be sequestered away from the rest of the marrow space under this canopy. And what's interesting is that you would think, since it's sequestered, where on earth do the cells come from? Well, it may well be that there's a vascular supply that actually abuts and may penetrate through the canopy and actually supplies some of the precursor cells required for this remodeling cycle. And in particular, as we'll talk about, osteoclasts arise from hematopoietic precursors, so they're coming from the marrow, and their origin is probably, their access to this area is probably through vasculature. The remodeling cycle in trabecular bone, in that thick column of bone, occurs in a somewhat different fashion. The principles are the same. It begins with a cutting cone that's activated by osteoclast, resorbing bone, followed by this reversal phase where there's not too much cellular activity, followed by the formation phase. And so what happens is, during the formation phase, you're digging this tunnel, you're like excavating a tunnel, and you basically close off the tunnel as the bone-forming cells close it in, but they leave a little central tunnel in the middle, and that's where the vascular supply to the cortical bone develops. And so when you look at bone in cross-section, when you look at cortical bone in cross-section, that's exactly what you see. Here is the central reversion canal where the vasculature is supplying, and here are the concentric circles of new bone formation that are occurring in a lamellar fashion around this cutting cone. And all these little black dots in here, those are all the osteocytes that are embedded in the bone and are controlling this whole cycle. Now, there is a further refinement of that bone remodeling cycle that I'll just touch on briefly, but it's kind of important because it really speaks to mechanisms of bone loss. And this is a sophisticated analysis that has pointed out that that simple linear progression I showed you, osteoclasts come, not much happens, osteoblasts form, and that's for the whole cycle repeating. Turns out it's not that simple. So what it turns out is happening is, yes, and this is mostly, we're talking about cortical bone, but it can happen in trabecular bone. There's initially a phase of resorption, but then during the formation phase, there's an admixture of osteoclasts and osteoblast precursors that are there. So they're concomitantly present. And what's happening is, during this period of time, you are racing against the clock. The osteoclasts are continuing to eat bone, and you're recruiting osteoblasts into this space. And there's a sort of a competition between the osteoclasts that are still there and the osteoblasts that you're recruiting in. And what it turns out is, if you divide this up into quartiles and you look at the number of osteoblast precursors that are present, resorption in this cutting cone only stops when you cross a threshold of about 39 osteoblasts per millimeter squared. And so when you cross that threshold, resorption finally stops. And really what that, as your number of osteoblasts are increasing, your number of osteoclasts are decreasing. But if you can't recruit osteoblasts fast enough, you just keep resorbing bone. So the way we tend to lose bone may be because we don't recruit osteoblasts fast enough to slow and stop osteoclast formation completely. And basically what this shows is that you have to reach this threshold density before you completely stop resorption. So the rate at which you recruit osteoblasts to this threshold, the faster you recruit it, the faster you stop resorption, the smaller the amount of resorption is. The slower you recruit osteoblasts, the longer the resorption phase goes on, the bigger amount of bone you resorb, and the wider this resorption cavity gets. Or in trabecular bone, the deeper the divot you dig is. And eventually, if you dig that divot deep enough, you actually perforate the trabeculae. So this gives us a much better understanding of how it is that this resorption phase goes on for a prolonged period of time in circumstances where we used to just think it was activated osteoclasts that are responsible for increased bone breakdown. It may be both not only increased osteoclast activity, but our inability to shut it off by recruiting the number of osteoblasts we need. So there are many systemic processes that can impact the rate of skeletal remodeling. I'm sorry, part of the slide's not on the screen. But just a few examples: hyperparathyroidism, estrogen deficiency, weightlessness, just to name a few. And here's an example of hyperparathyroidism where there's a markedly increased number of osteoclasts present, markedly increased number of osteoblasts. This process is turning over very quickly. And for reasons that we don't fully understand, when this process occurs at a very rapid rate, you get this marrow fibrosis, which may be aberrant or incompletely differentiated osteoblasts. So now we're going to talk a little bit more about the cells of the bone remodeling cycle. Again, the cells that form bone are the osteoblasts, the cells that break down bone are the osteoclasts, and the osteocytes buried in bone are the cells that run the whole show. So we'll start with osteoblasts. They arise from a pluripotent mesenchymal stem cell. These are cells, again, resident in bone, can have a number of fates. Among them, here's the precursor cell. It can turn into a muscle cell, it can turn into a chondrocyte, it can turn into a fat cell, or it can turn into an osteoblast. And there are a whole host of hormonal and cytokine factors that regulate the distribution of these mesenchymal stem cells to these various fates. Their main job in life is to make type 1 collagen, which is the principal component of that provisional scaffolding that we need to make before we can mineralize it as new bone. It's largely type 1 collagen. They make matrix vesicles that are highly concentrated in calcium and phosphate that they extrude into the extracellular space and initiate the process of mineralization. So they're like masons. They put down the initial framework for the stucco, and then they come in and they actually put the stucco on. So the chicken wire mesh is the proteinaceous scaffolding. The matrix vesicles provide the actual cement that you now put down. They make alkaline phosphatase, which cleaves pyrophosphate, and a potent inhibitor of mineralization. And this is a fascinating area that I won't bore you with. But the way Mother Nature controls many processes is by tonically inhibiting it and then disinhibiting it when he or she wants something to go forward. And we'll see that theme again. So in mineralization, the reason we don't turn into stone everywhere is in part because we have mineralization inhibitors in our vasculature, in our brain, in our kidneys that prevent us from mineralizing that tissue. In bone, we have pyrophosphate, which prevents mineralization. And alkaline phosphatase, good old bone-specific alkaline phosphatase, cleaves pyrophosphate. It breaks that pyrophosphate bound, and it allows mineralization to occur. And interestingly, these cells are relatively short-lived, about 90 days. So when we were talking about that process of competition between osteoclasts and osteoblasts, the recruitment of osteoblasts from mesenchymal stem cells has to occur at a fairly robust rate to stop that process, to allow cells to be available for new bone formation. So as I mentioned, there's a tug and pull because these mesenchymal stem cells can have multiple fates. And I just want to highlight the clinical relevance of one of those fates. So PPAR gamma is a master regulator of the decision of whether a mesenchymal stem cell turns into a bone-forming cell or an adipocyte, a fat cell. So one of the common drugs we use to treat type 2 diabetes are thiazolidinediones, which of course are very effective at reducing peripheral insulin resistance, have been shown to reduce the risk of stroke, but time and again have been shown to increase fracture risk. And this slide shows that when you give TZDs to humans, the amount of fat, third time's a charm, the amount of fat that's present in the femur and the amount of fat that's present in the vertebrae goes up. So this is suggesting that, as you might expect from the biology, that mesenchymal stem cell is now being driven to a fat cell and not to an osteoblast. So now you're impoverishing your ability to make osteoblasts. And what happens as a consequence of that? Well, this is a recent post hoc analysis we did of a large clinical trial that was designed to look at the benefit of pioglitazone in patients who were insulin resistant but didn't have frank 2 diabetes and their risk of stroke. And in fact, it showed that it reduced the risk of stroke, but unfortunately also increased the risk of fracture. So as compared to placebo, the cumulative probability of not having a fracture was markedly lower if you took pioglitazone than you took placebo. So there's a real-world example of how a drug we use for an entirely different purpose affects a very fundamental process, which is how we make bone or fat in our marrow. The osteoclast is a cell that initiates the bone resorbing process. It's the cell that breaks down bone. Like the osteoblast, it's a very complicated series of steps that lead to its final mature biology. It's a highly complicated cell. It's a Pac-Man that just eats bone, but it's interesting because its ability to do so requires a highly specialized subcellular analysis. And what's interesting is it seals itself against the bottom of the bone, eats the piece of bone, and transits the piece of bone right through its head. It just pops right out the top of the bone. So it extravasates these vesicles of bone that have been eaten right out the top of the cell. It arises from cells, a precursor in the monocyte macrophage lineage, so it's clearly of hematopoietic origin. And here's what it does. It eats these little discrete holes in bone. This is actually dentin with osteoclast seated on it, digging these little deficits, and that's the first step in the typical bone remodeling cycle. It's highly specialized multinucleated cell in bone that resorbs both the inorganic and organic components of bone. It moves along the bone surface, creating these resorption pits. Multiple different genetic defects in the resorption machinery give rise to the clinical syndrome of osteoporosis. So because it's so complicated, if you screw up on one little tiny bit of its resorption machinery, it can't do its job. And we need osteoclasts. Although we try to kill them dead and make them sick as part of our treatment for osteoporosis, under normal physiologic conditions, if you don't have osteoclasts, you can't renew and remodel your skeleton, and it turns into chalk. And that's what osteoporosis is. Those are people with incredibly dense bones, but very weak bones who paradoxically will fracture their bone. And they have a very short half-life, 10 to 14 days. So another cell that requires constant renewal. So this is a video clip of an osteoclast just to show you how dynamic they are. Can you just run that video? This is a cell that was treated with a hormone that normally stimulates them to move toward an area of resorption. But I just showed this to you to show how quickly, this is a video over like 5 minutes, and all of that change occurs very rapidly, and it shows you how quickly they can remodel the intracellular machinery to form these areas where they stimulate resorption. So a very dynamic cell. And as I just said, suppressing osteoclast is not a good thing. So we know that certain drugs, if used to excess, oversuppress bone turnover, and the bisphosphonates are one of those drugs, so we're now more careful about how long we use these drugs. That was brought to our attention by papers a number of years ago pointing out that normally you can see on a bone biopsy evidence for cellular activity, bone formation. This is the osteoid, these are the osteoblasts. But in patients who have been oversuppressed, their turnover has been oversuppressed, you basically have a desert. There are no cells present. And the great fear is that if you oversuppress bone turnover, that may contribute to these incredibly rare fractures called atypical femoral fractures that have received a great deal of attention and scared a lot of people away from therapy. We don't know whether oversuppression of osteoclast activity is the sole reason for these fractures. But there's a suspicion that it contributes to it, and it's not unreasonable to believe that it plays a part in that pathogenesis. So now to the osteocytes. These osteocytes arise from osteoblasts, the same cells that form bone. A chosen few don't die, but are anointed to become buried in bone, entombed in bone, where they assume a whole different life, which is to regulate osteoblasts and osteoclasts. It's unclear how particular osteoblasts are chosen to become osteocytes. With other osteocytes, they form a dense network of interconnected cells, which I'll show you, that look for all the world like a neural network. These cells live in fluid-filled lakes called lacunae that are connected to each other by canals or canaliculi that are the pathways for the dendritic processes that connect osteocytes to one another. So this is the Venetian canal system of your bones. They are the mechanosensing cells in bone. Pressure on bone displaces the fluid in the lacunae and canaliculi, which is sensed by the cells. And they are critically important because they control the bone remodeling cycle by regulated expression of two cytokines we'll talk about, rank ligand and sclerostin. And unlike any of the other two cells, they are very long-lived, 10 to 20 years in lifespan. And when they die, they don't get easily replaced. So here's the dendritic processes. This is bone tissue in which the bone tissue, the mineral tissue has been etched away, and we can see these dendritic processes that connect the osteocytes to one another. Here's the osteocyte body that lives in this fluid-filled lacunae, and by processes we don't understand, they prevent themselves from turning into stone by inhibiting resorption in their immediate vicinity and the immediate vicinity of the dendritic processes. And again, when you lift weights, when you walk, you create pressure on this bone that is transmitted to the fluids surrounding these cell bodies, surrounding these little dendritic processes, and the fluid moving back and forth, oscillating back and forth, activates little connections on the surface of those cells that turns into a chemical signal that turns into the ability to remodel bone. Also, when you fracture a bone, what you do is you fracture through this dense network, and that fracture signal sends an SOS signal. It tells these cells that something bad has happened, and they send out the signals that then initiate the repair process. So as I mentioned, osteocytes are buried in bone. They have projections that connect them to one another. They are also connected to the cell surface, where they regulate the recruitment of osteoclasts, the bone breakdown cells, and osteoblasts, the bone-forming cells. And the two final common effectors of those processes are rank ligand that stimulates osteoclast activity and formation, and sclerostin, which inhibits bone formation. So just like we were talking about tonically inhibiting bone formation, the tonic inhibition of bone formation is affected by sclerostin. This hormone, this cytokine, inhibits bone formation, and when you want to turn on bone formation, you suppress sclerostin. And here's an example of that. This is a turkey wing that has been bent. And where you see the double lines, you're getting bone formation. So this is the mid-shaft of the turkey wing that's not been loaded, not been repeatedly bent. This is the turkey wing that's been repeatedly bent. And you can see there's way more bone formation in this bone than there is here. So there's two colors in several places. There's virtually no two colors here. And why is that? If we look at the sclerostin expression in the unloaded bone versus the loaded bone, these little dots represent the messenger RNA for sclerostin. It disappears when you load the bone. Here's the protein expression. It disappears exactly where the bone formation occurs. So this is a marvelously specific process. This is why a professional pitcher has a higher bone mass in his serving arm than his non-serving arm, in his pitching arm than his non-pitching arm. That's why Vanessa Williams has a higher serving arm in her serving arm than her non-serving arm. It's because the muscles pulling on that bone exerts pressure on that bone that's sensed by the osteocytes that results in them turning off sclerostin. And that's how we build bone when you're a professional weightlifter. You weightlift all your life. You gain bone in your muscle. You gain muscle because your muscle mass is so big during your bone-forming years. You're shutting down sclerostin and turning on bone formation. Conversely, in reduced gravitational field, the osteocytes are not subjected to normal mechanical strain, and the result is profound bone loss. The osteocyte is sort of a mechanostat. It says, how much bone does Carl really need? I mean, if he's 60, does he really need as much bone mass as he did when he was 20? Or if he's up in space, it doesn't look like he really needs any bone at all. So for reasons that we don't understand, when it loses that mechanical strain, that gravitational pull, it says, okay, you don't need that much bone. So what happens is you get profound bone loss, and that's a real problem when we're going to send people to Mars. They're going to be invertebrates by the time they get here if we don't figure out how to prevent that. So here's astronaut Donald Pettit returning from 191 days in space. He's literally so weak he can't walk. They had to carry him out of the space capsule to the medicine tent. So they lose a tremendous amount of bone. They lose a tremendous amount of muscle strength. And it's a major problem that's a major NASA effort now, is to try to figure out how we're going to prevent that from happening. They've obviously tried exercising in space that attenuates it. Some of the newer drugs we have been tried that look like they may help. But there are other physiologic changes, as you may know, in the heart and the eyes that are also pretty concerning. So we talked about the bone remodeling cycle, and one of the truisms is that under physiologic circumstances, the bone remodeling cycle is tightly coupled. This means that if you inhibit bone resorption or bone breakdown, you eventually inhibit bone formation. Conversely, if you stimulate bone formation, you eventually induce bone resorption. There are circumstances, though, where that tight coupling is uncoupled. One of them is during growth, when we're obviously making more bone than we're losing it. And then the other time is after menopause in women and older age in men, where you're losing more bone than you're forming it. But there are certain experiments of nature that have highlighted some of the critical factors that couple these two processes. And one of them is Wnt signaling in bone. Wnt is a molecule that's mostly studied by fly biologists until relatively recently, but it turns out that Wnt signaling in bone suppresses rank ligand and suppresses sclerostin. So when you turn on Wnt signaling, you're suppressing bone breakdown, and by suppressing sclerostin, you're forming bone. So this, in fact, uncouples bone formation. This allows you to form bone at the same time you're inhibiting osteoclasts. So what I just told you, the paradigm when you break down bone, you form bone, and when you stimulate bone formation, you stimulate resorption. This process actually uncouples it. So here's the experiment of nature that made Wnt signaling a therapeutic target. This was about 16 years ago. Two groups, one our group at Yale and another group in Omaha, simultaneously made this discovery. And in our case, it was based, ironically, on the case of Mr. Light. Mr. Light has an interesting party trick that he does. Mr. Light cannot swim. His bones are so dense that he can fill his lungs with air and sink to the bottom of a pool. So this is a party trick he does for his family. Can you run the video? So what I'm going to show you is Mr. Light.
Perhaps one of the most interesting research programs regarding osteoporosis has to do with this man, Richard Light, from Danbury, Connecticut.
We have a number of projects here. The one that I'll tell you about is a project that stems from a patient that I saw who had extraordinarily high bone density. In the course of studying that man, we were led to his family, many of whom had similarly very high bone density. That, in collaboration with a group of geneticists here at Yale, allowed us to identify a gene in that family that had a mutation that resulted in this very high bone density in this family.
And he said, do you mind if I pass this information along to someone?
In fact, Richard Light's T-score goes well above the normal range. Instead of having a normal T-score that hovers around 0 to the +1 range, Light's total T-score for a lumbar spine scan is 7.7.
The extraordinary thing is that these people have very strong but also very good bones. These bones are structurally extraordinarily strong, and folks in this family with this mutation don't ever have fractures. So he tells this great story about how he was in this multi-sport competition at a Club Med in Mexico where they had to run and sail, and then the final part of the competition was swimming, and he was winning. He was really excited. He was winning. He got to the pool part and he like tanked, literally. He didn't win. He lost. So the thing that his condition was due to was to an aberrancy in Wnt signaling. So Wnt signaling is a complicated process in which two receptors, LRP5 and Frizzle, these were all named by fly geneticists, so they like all these weird names. When you bind a Wnt ligand to this signaling complex, you activate bone formation. But because it's such a potent signaling system in so many different tissues, Mother Nature has a whole series of ways to inhibit it. One of them is by an endogenous inhibitor called DKK1. But Mr. Light had a mutation that prevented DKK1 from binding LRP5. And so essentially, his bones turned on Wnt signaling much more than you and I because he was resistant to this inhibitor. And that's why his bones got so dense. But unlike people with osteoporosis, his bone remodeling cycle was intact, and his bones were incredibly strong and structurally very good. So from a clinical practice standpoint, we'll come back to Mr. Light and why his experiment of nature is important therapeutically. From a clinical practice standpoint, bone remodeling cycle can be disturbed in two major ways in adults. One is by osteoclast-mediated bone loss, and that's when osteoclast activity is increased, the resorption pit you dig is too deep, and now we know it's not simply because of too many osteoclasts, but it's not enough osteoblast recruitment. You attempt to fill that in, but you don't completely fill it in. So with every turn of the bone remodeling cycle, you lose bone. In later adult life, your osteoblasts get tired. The resorption pit is not that deep, but you just can't fill it in with new osteoblasts, and you lose bone. So since the initial focus in treating osteoporosis was postmenopausal osteoporosis, in postmenopausal women, it's osteoclast-mediated bone loss that seems to be the principal mechanism. So increased bone breakdown seems to be the most common reason for accelerated bone loss, particularly following menopause. And the initial focus of drug discovery was therefore on inhibiting bone breakdown. Anti-resorptive agents are usually the initial approach to treating this disease, although as you will hear about in this conference, there's an interest in treat to target, which would argue for starting anabolic agents if the bone density is very low. And I won't cover that topic here, but you'll hear about it more here. But that notwithstanding, we were very successful in developing a whole series of very effective, very potent anti-resorptive agents. Those included the bisphosphonates, which are shown here, alendronate, risedronate, zoledronate, abandronate. And then we'll come to denosumab, which acts by a different mechanism, but is also an anti-resorptive agent. And they are all very effective at reducing vertebral fracture, hip fracture, non-vertebral fracture. The only one that was not formally shown to reduce hip fracture was ibandronate. They all act, except for denosumab, the bisphosphonates all act in the same way. They bind in bone at the site of resorption, which is good. The osteoclasts eat them, and the osteoclasts get agita. They get sick to the stomach. It disturbs their ability to make that complex cellular machinery to resorb bone. And when they get sick to the stomach, they just can't eat the bone. They die to a certain extent, but mostly they're just sitting there feeling bad, looking for Alka-Seltzer, not able to resorb the bone. That's a little different than denosumab. Denosumab is like raid, it kills them dead. But be that as it may, the central process here is just stopping resorption. We're not really forming new bone, we're stopping bone breakdown. But because with increased bone breakdown, you have a lot of open resorption lacunae, and particularly with high rates of resorption, you can actually perforate trabeculae. Even though the amount of new bone you form with these drugs is modest, 5, 7, 10, maybe 11%, the anti-fracture efficacy is profound because the rate of remodeling is a separate and independent risk factor for fracture. And the way I like to explain that is if you take a board and you punch a hole in it and you bend the board, where's it going to break? It's going to break where the hole is. And so you haven't changed the mass of the bone very much, but statistically, if you have a bunch of holes punched in that board, you've made it structurally less sound, so it's like a trabeculae. If you have a high rate of resorption, at any given time you've got trabeculae with multiple holes punched in it. And even if your bone mass hasn't gone down that much, that bone is structurally impaired. You shut down resorption, give you a chance to fill in the holes. You're not getting a whole bunch more new bone, but you're filling in the holes and making it much more structurally sound. So you increase bone mass by 11%, you decrease fracture risk by 40, 50, 60%. That's why there's this big disconnect between those two phenomena. And that's why we see these marked improvement in fracture risk with drugs like zoledronate, one of our most effective anti-resorptive agents. This is looking at morphometric vertebral fracture in the first year, second year, third year. And I won't go these slides in detail. The blue line is the zoledronate group. This is cumulative incidence of hip fracture, non-vertebral fracture, clinical fracture, any clinical fracture. The drug is incredibly effective, incredibly robust in its action. And again, it's very specific, binds in bone, doesn't bind anywhere else, binds at sites of active resorption, gives them agita, very long-lived in terms of its response. But of course, what we hear about every day is, oh my God, they're going to kill me. Osteonecrosis of the jaw. This is a dental mirror, so that's why it's kind of a weird picture. But the sine qua non of osteonecrosis of the jaw is exposed bone in the jaw. It's one of the hallmarks of the disease. So when patients come to you and say that their teeth feel funny or they swear their teeth are loose and they know they have osteonecrosis of the jaw, they don't. Osteonecrosis of the jaw is a very specific diagnosis and usually requires having exposed bone in the jaw. It's incredibly rare. I've seen it once. I've seen it in, and I can't tell you how many patients, I'm sure you have the same thing happen to you. Patients come and sure they have it. It's important to work with a dentist who knows something about this. So they're not going to believe you that they don't have osteonecrosis of the jaw. You need to send them to a dentist or an oral surgeon who has some knowledge about this. And I've got one in Connecticut that I refer people to who knows about this disease, knows the distinguishing features between them. The only patient I ever saw with this disease, and the place where this got on the map was in patients with cancer who were getting industrial doses of these drugs, zoledronate once a month, for example, for myeloma. Yeah, and in that circumstance, you can see this. The other one is atypical femoral fractures, again, an incredibly rare side effect. It is clearly has a higher incidence in this meta-analysis of patients looking at all case control studies, estimating a slightly increased risk of atypical femoral fracture with prolonged bisphosphonate use. So those risk factors, as I'll come to, Those risks are incredibly rare and really should not be determining factors in whether to initiate therapy. And I think we really need to educate people about the relative risk-benefit of these side effects. As I mentioned, rank ligand, so we've talked about the bisphosphonates and how they give osteoclast agita. Rank ligand, again, is the final common effector for osteoclast formation. No matter what hormones are affecting bone resorption, PTH, estrogen deficiency, in the end, they're acting through rank ligand. And there was no moss growing under the feet at Amgen. They developed a blocking antibody to rank ligand, and that antibody is Denosumab or Prolia. And of course, it is potently effective at inhibiting osteoclast bone breakdown. Again, this is looking at new vertebral fractures, time to first non-vertebral fracture, time to hip fracture. Huge separation from the placebo group. And this is the most potent anti-resorptive agent we have. It kills osteoclasts dead. Not forever, because you keep making them. They have a pretty short half-life, 10 to 14 days, which is why you have to give the drug every 6 months. But as an indicator of how dead it kills osteoclasts, if you give somebody zoledronate or alendronate, and if you use CTX as an index of rate of bone breakdown, if somebody starts with a CTX of 600 when they're on alendronate after a couple of months, the number will be 200, 150. You give somebody Prolia, it goes from 600 to 50. So it really knocks down resorption. It has the same super rare side effects associated with it that the bisphosphonates do, again, mostly seen in my experience in cancer patients. And one of the interesting things that sort of points out how potent it is that in this meta-analysis of 4 clinical trials of Denosumab compared with bisphosphonates in postmenopausal women who had been previously treated with oral bisphosphonate. So everyone here had already seen a bisphosphonate. If they then got continued bisphosphonate, as opposed to being switched to Denosumab, there was a much greater increase in bone mass when you switch to Denosumab. So there is an increment of further suppression of bone resorption that you can achieve by switching to these drugs. If you're not getting adequate suppression of bone resorption with a bisphosphonate, most of the time it's because of noncompliance. There may be circumstances in which there's a secondary reason that's driving accelerated turnover, such as myelodysplasia or hyperparathyroidism, but I don't point this out to suggest that you should reflexively switch people to Denosumab. I point this out to point out that there are degrees of suppression that can be achieved with these different drugs. And one of the disadvantages of Denosumab is it's so effective at suppressing resorption that when you release that suppression, there's a rebound effect such that resorption increases past baseline and unfortunately is associated with an increased risk of fracture. So this just shows the change in a lumbar spine bone density during the Denosumab group, and then you stop it, and you lose everything. Lose it at the hip, lose it at the wrist, as compared to the placebo group. So you take back everything you gain. That mechanostat is difficult to convince that you've set a new steady state. You're pushing a rock uphill. You're fighting against a mechanostat that says, Miss Jones at 70 only needs this much bone. You can build her back up, but unless you do something else, I'm going to dribble her right back down to where she was before you started the treatment. And the problem, of course, is associated with that accelerated resorption is an accelerated rate of fracture risk. So if you look at the relative risk of fracture in the group that goes from placebo to placebo, you see that there's not much change. If you look at the risk of fracture in the Denosumab group switched to placebo, there's a huge increase in the risk of vertebral fracture. And the vertebral fracture rates, again, not much change with placebo, but off treatment, dramatic increase. We are learning now how to prevent this, but we don't have all the answers yet. Interestingly, because you shut down resorption so completely, if you give a bisphosphonate immediately after stopping Denosumab, it's like trying to get things to stick to a plastic surface. They just slide right off. They need resorption sites to stick down. So it's like trying to get oil to stick on saran wrap. It just won't stick. You need to allow resorption to resume before you begin to suppress this increase in resorption that occurs. And this just highlights the fact that as you stop the Denosumab, you get a marked increased risk, in the relative risk of fracture off Denosumab. So we have now potent ways to suppress resorption, but that also suppresses formation, and that leads to low turnover, which can potentially be a problem. But can we uncouple turnover? And so the drugs that we have right now are the drugs that activate the PTH receptor. They're PTH receptor activators. There are two of them, teriparatide or Forteo, and the new one, abaloparatide or Tymlos. They both act by intermittently activating the parathyroid hormone receptor. So they both act in the same way. They bind to the receptor on the surface of osteoblast precursors. They stimulate differentiation of bone lining cells in pre-osteoblasts. They reduce the death of osteoblasts. And the net effect is an increase in the number and action of bone-forming cells, including on quiescent surfaces. So that's what we were looking for, a drug that actually activated formation on surfaces where there hadn't been resorption before. And the two drugs, as I just said, are teriparatide or Forteo and Tymlos. This is parathyroid hormone, the same thing you make in your neck. And this is a derivative of another more ancient hormone that we use locally to regulate a variety of processes, including chondrocyte differentiation, which now has been co-opted by us as a therapy. And these slides shows that they open an anabolic window during which bone formation is stimulated first, followed by bone resorption. So you don't completely uncouple bone turnover, you get a jump start. You initially form bone faster than you're stimulating the resorption, and that disparity opens what I call an anabolic window during which you get bone formation. But eventually the resorption catches up and it sort of attenuates the anabolic response. So the biggest bang for your buck with these drugs is in the first couple of years when you use them. And so it's that eventual catch-up that intrinsically limits the anabolic response. That compensatory resorptive response is somewhat attenuated with abaloparatide, And so that's why the anabolic window appears to be a little bigger with abaloparatide. So these are the teriparatide studies. The CTX goes up with, this is the bone resorption marker. You see P1NP goes up quickly. In those first 12 weeks, it's up much more rapidly and to a greater extent. It's still up to a greater extent in the 12 to 24 weeks, but the CTX is rising further and starting to catch up. With abaloparatide, there is an initial increase in resorption, but it doesn't really continue up. The response in formation is more modest, but you can see that because this is declining, the anabolic window stays open longer. So although the whole process isn't as robustly stimulated, there does seem to be a disconnect between the resorption and formation phase. It's not completely uncoupled, but it does result in a better anabolic response. So in this study comparing teriparatide to abaloparatide, there's a better increase in total hip bone density, femoral neck bone density, and a slight but not statistically significant increase in lumbar spine bone density. But certainly at sites that we worry a lot about, where we haven't had drugs that don't have much of an anabolic effect, it's nice to see a drug, particularly the femoral neck, which, as most of you know, is a very recalcitrant area to get a good therapeutic response. It's nice to have a drug where you see a pretty robust anabolic response. And that translates into better clinical outcomes in terms of non-vertebral fracture risk. This is a more rapid, more robust reduction in non-vertebral fracture, in clinical fracture, and major osteoporotic fracture. So that more robust anabolic response seems to translate into, at least in the initial 24 months, a more robust reduction in fracture risk. And although I'm not sure we're ever going to get to it, it looks like simultaneously administering teriparatide with denosumab results in a better increase in bone mass than either one alone. So here's teriparatide year 1, year 2. These are the percent increases in bone mass. You can see, again, it tapers off in year 2. But when you add the two together, at all these sites, they outperform each other. And the underlying mechanism is purported to be that what's happening is that you are shutting down resorption with denosumab, but you're allowing that a modeling component, that new bone formation that occurs on quiescent surfaces, to be exposed. So you're allowing the formation component of teriparatide's effect and presumably abaloparitide's effect to be more manifest. And that's why you get your better bang for your buck. I think the histologic proof of that is still wanting. When you combine alendronate and teriparatide, you don't get nearly as good a response. You get a response in some tissues, but not other tissues. So this is not something we should be doing. Whether this will come as an FDA-approved therapy, I think, is still an open question. But what is very important about using teriparatide and abaloparatide, as you probably know, is that in that circumstance, because resorption is turned on, you will lose all that bone again because the mechanostat says you don't need this bone, so you need to give an anti-resorptive agent. And because resorption is turned on, you can lock in your formation with an anti-resorptive agent very effectively right after stopping teriparatide or abaloparatide. So this just shows that after teriparatide for 12 months, if you give an anti-resorptive agent, in this case alendronate, you prevent the bone loss. If you give nothing, you lose the bone loss. If you give it, you prevent the bone loss at the hip. If you give nothing, you lose the bone. So you need to give an anti-resorptive agent because, again, otherwise the mechanostat will reset you. Now, for the parathyroid hormone receptor agonists, we've gotten closer to where we need to get. But when I told you about Wnt signaling, I told you that that looked like the holy grail. I mean, you basically stop resorption and you stimulated formation. And so when Wnt signaling is activated, again, osteoclast activity is suppressed, so is sclerostin, and you're thus truly uncoupling bone formation. And sclerostin is a particularly appealing therapeutic target because its expression is restricted to bone. So if you target that, you're not going to have any off-target effects. It's only made in the osteocyte. So based on that biology, you would predict that suppressing sclerostin would uncouple bone remodeling in favor of formation. Of course, first to the table again was Amgen. They made a monoclonal antibody that blocks sclerostin and showed tremendous clinical potential. In initial clinical trials, it looked exactly like what you would have thought. Here's the formation marker, a dose-dependent increase in this formation marker over a 75-day study, and no change in resorption, none. So you completely uncoupled bone turnover. And by this time, if there was going to be an increased bone formation, bone resorption in response to the formation, we should have seen it, but we saw nothing. And so they developed a drug, Denosumab. And Denosumab looked like it was going to be the greatest thing since sliced bread. It far outperformed any other anti-resorptive agent or anabolic agent we had. So this is placebo, alendronate, teriparatide, and this drug, Denosumab. Like any monoclonal antibody, has to be given frequently. I think here it's monthly. But the percent changes in the lumbar spine, total hip, and femoral neck were huge compared to the changes that we saw with any of these other agents, and it showed a markedly reduced incidence of new vertebral fracture. There was a trend toward a reduction in the non-vertebral fracture. A part of this was because the details in the recruitment that Felicia Cosman could tell you a lot about in terms of why the particular patient population turned out to be enriched with patients from South and Central America who had a very low hip bone density, hip fracture risk, which attenuated the anti-resorptive effect of the hip. But in a sub-analysis, when you just looked at the data from the European and North American cohorts, there was a robust reduction in hip fracture. So, made lots of bone, made good bone. And I'm sure many of you were thinking about running out and buying stock in Amgen. And in fact, when you looked at the end fracture risk, continued fracture risk reduction 12 months after Denosumab, because like any anabolic agent, it's given for a short period of time, followed by Denosumab for another 24 months in this phase 3 study, there was a marked reduction in fractures in every category. Vertebral, clinical, non-vertebral, major non-vertebral, major osteoporotic fracture, worsening of vertebral fractures, newer worsening vertebral fracture, clinical or worsening vertebral fracture, a trend toward reduction hip fracture, again, because of what I mentioned. And robust numbers of study subjects. You know, this was a hugely expensive multinational study. And then they did a study, an active comparator study, comparing alendronate to Denosumab. And it outperformed alendronate. Clearly better at reducing new vertebral fracture, clinical vertebral fracture, and non-vertebral fracture with a significant reduction in hip fracture. Unfortunately, in that study, there was a slight increase in serious cardiovascular risks, with 2.5% in the romosozumab group, 1.9% in the alendronate group. Cardiac ischemic events were also unbalanced, with an increased but very low incidence in the romosozumab group, and scarily cerebrovascular events. So this drug is now on hold at the FDA. They're being asked to adjudicate their other trials for cardiovascular signals. So in summary, bone modeling refers to two processes. Most common is the process of bone growth and sculpting during fetal development, childhood, and adolescence, ending with epiphyseal closure. It also refers to the formation of new bone on quiescent bone surfaces. Bone remodeling is the process by which mature bone renews and repairs itself. It occurs in discrete units, sites along trabecular cortex, mediated by the basic multicellular unit. As I hope you remember now, that process is not a linear process, but really a patchwork process, which is really kind of interesting, and it shows you that if you don't recruit osteoblasts fast enough, that process continues to go on, and you really need to turn off osteoclasts by turning on osteoblast recruitment. Remodeling is affected by many local and systemic processes and hormones, as we talked about: weightlessness, estrogen deficiency, parathyroid hormone excess. The science of the bone remodeling cycle underlies all therapies, therapeutic approaches to treating low bone mass. Anti-resorptive agents inhibit osteoclasts or induce their apoptosis. That's Denosumab. They significantly reduce fracture risk, but because they cannot uncouple bone turnover, they result in only modest increases in bone mass, but still profound reductions in fracture risk. Intermittent activation of the PTH receptor does open an anabolic window and does stimulate formation on quiescent surfaces, i.e. modeling, but eventually resorption is stimulating, limiting the anabolic response. Directly targeting osteocytes, which regulate bone remodeling by their expression of rank lichen and sclerostin, is an untested therapeutic approach. Since they are the mechanosensors, one conceptual approach is to change the mechanical set point. So if we could figure out the chemical signals that set the osteocytes mechanostat and somehow ratchet it back to 21, they would do the job for us. They would make your skeleton a 21-year-old skeleton for you. We aren't there yet. Inhibiting sclerostin, which is a product of osteocytes, and de-repressing Wnt signaling does completely uncouple bone turnover in favor of bone formation, the holy grail, almost, but may have risks we don't fully understand. And by that I mean it seems like, and this may be happenstance, but it seems like if you turn on bone formation in certain ways, you may wind up turning on bone formation in other sites. And that's one of the nagging questions that we need to answer about this signal with romosozumab. Are there effects on the bone, nascent bone-forming qualities seen in vasculature that may underpin this? So I'll leave you with that. Thank you very much for your attention.